Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot. And today I'm delighted to be joined by Dr. Richard Milani. He is the Chief Clinical Transformation Officer at the Ochsner Clinic. His specialty was in preventative medicine and clinical epidemiology, and he's also a cardiology expert. Richard, thanks for joining me today.
Thanks for having me, Nick. It's my pleasure.
So I had the privilege of attending a session that you gave at HIMSS just recently, part of the AMDIS pre-conference workshop. You shared an incredible vision and challenge of the healthcare system. You shared a lot of, really quite depressing statistics in terms of our successes. And one of the things that really stood out to me in that was the challenge of changing behavior and the difficulties that we have that are represented both in terms of the way that we practice medicine, but also importantly, the impact that medicine, healthcare, as opposed to all the other influencing factors. Could you share a little bit of the background, the details of what you talked about there?
Yeah, well, again, it all started back from the recognition that the epidemic that we face today across the planet, and especially in the United States, from a health perspective, is chronic disease. Chronic diseases are predominantly generated through behaviors, and moreover, it's one of the few tools we have to actually influence the outcome in chronic disease, whether it be diabetes or hypertension or heart failure or COPD or any of these processes. So when you look at it from a mechanistic perspective, from a healthcare perspective, a delivery perspective, the only levers that we have to control in terms of changing the outcome for any individual that we see with any chronic disease is really getting people on the right medications, and then getting people to modify behaviors that influence that chronic disease. So behavior change and behavior modification is really a critical component in treating the largest epidemic facing us from a healthcare perspective, and yet we don't necessarily do a very good job of it. And there's a lot to learn about impacting behavior from a healthcare perspective.
So you bring up another one of my sort of areas of passion, the aspect of contribution to disease. And I'm trying to recall the number you cited as non-healthcare, but rather the sort of environmental. How does that break down? What's going on in terms of why we get disease, and how we can then influence that from a positive standpoint, both with healthcare and medication, but importantly, behavioral change?
Well, if you just look at the contributions to an individual's health over their lifetime, and you were to break this down, we know that the healthcare systems, the doctors and hospitals that we all utilize, do have an impact on our long-term outcomes, but it's relatively small. It's anywhere in the 10 to 15% range. When you look at health behaviors, so, what you do in your life, do you smoke, do you exercise, what do you eat, how you eat, sleep, everything else, that's about 40% of your entire health outcomes, more so than even the contribution your parents make, meaning your genetics, your genes, which is right, 30%. So behaviors are critically important in all of our healths. And how can we learn to adopt healthy behaviors and understand what those are and displace maybe less healthy ones? So it's such an important part of all of us in our health, and it's certainly an important part of treating somebody that we really need to improve our capabilities in terms of generating behavior change.
So you're clearly in a circumstance, both, from the fact that you're, recognizing this, essentially calling this out. What are you doing about it? What's going on in your clinical practice? How are you addressing this? Because, when I look at that 10 to 15% of contribution versus how are you addressing this?
Well, I think it's a recognition that, from a national and international perspective, we're not doing a great job in managing chronic disease, which is, again, responsible for about 70% of all the deaths across the United States from a health perspective. And it's about 86% of all the dollars that we spend in healthcare across the nation. So, I mean, it's clearly the elephant in the room. So the first thing is a recognition that we're not doing a stellar job. The second is we really need to sort of re-engineer how we deliver care to patients with chronic disease. It's just the analog model that we have today of, making an appointment, coming into the office for your 6-month or annual or whatever it might be checkup is really inadequate to manage processes that are changing weekly, if not daily. So we need better tools. Secondly, the concept that if I just give you a handout that talks about the disease, don't get me wrong, I think that's important to do. We should not deprive patients of information about the process. But if I just give you a simple handout in my short 15-minute office appointment, that's not going to be sufficient for the majority of people that you interact with to change their behavior and to adopt new choices, whether it be food choices or exercise or whatever have you. So we need to have some sort of a more long-term capability and tool set to be able to help people and guide people along the path towards a healthier life.
And I think you shared some of the details of what's going on in the Ochsner and the patients that you have, and some of the successes that you've seen as a result of this.
Right. So we've actually taken on this task, and we certainly don't pretend to be experts in that. We've done it. It's perfect. We don't need to make any more changes. Just follow us, and it's all good. But I think we've made a lot of progress. So we've developed a kind of a focused factory model where we follow patients and manage patients all digitally, actually virtually, so that we have multiple interactions, not just 2 or 3 in a year, but we have multiple interactions each month or each week with patients, and it's a continuum that doesn't stop, so that we can help see what's going on, have some visibility into their disease control, and provide a more personalized approach towards not only treatment, but also towards behavior and behavior change.
Yeah, so, and that's, as I tease out some of the things, so there are some key learning points from my perspective. The first is, and it feels a little bit like Alcoholics Anonymous in some respects, it's that acknowledgement is the first step, which is, we're not doing a good job. And then the way I put this is, don't let perfection stand in the way of progress, which you've clearly sort of taken on and said we're not experts. Interested to understand a little bit more about the digital aspect of this. So that's one of the things that, I hear a lot in the marketplace, colleagues and so forth, who say technology is not going to solve this problem. It's people, and then vice versa, depending on but it sounds like you're blending those two to deliver the value, right?
Yeah, I think you said it well. Technology is not going to solve the problem, but technology can be a big enabler for us in helping us solve the problem. So, for instance, the purpose of the technology is multiple. But first of all, how am I going to manage somebody whose disease is changing, say, every 3 or 4 or 5 days, by sampling what's going on with that disease 2 or 3 times in a year? And the answer is, I'm not going to be able to do a very good job, obviously. I mean, just imagine running your business that way. If you were in some kind of a business where you're in a manufacturing business or something, you'd want to know how sales are in all parts of the country or the world. And you'd probably want to look at that daily just to keep up with trends and changing things. But yet in healthcare, where we're talking about somebody's life, we're sampling a blood sugar from them where they bring it in, or a blood pressure, or whatever else is going on with their COPD or something else, maybe just when they come in and see us, which is maybe once, twice, 3, 4 times in a year. So the first is that recognition that we have to have a sampling frequency that comes close to the changes that are taking place in the individual. And so that's where technology can help, where we can have some home-based technology that can feed us that information and then alert us if people are starting to head out of bounds, for instance. They're doing well, but now you're inching towards not doing so well. And that'll give us a heads up that we need to do something. So that's one of the ways that technology can really enable us. The second, of course, is that we need multiple forms of communication other than face-to-face. So right now, again, in the analog world, you have to come in and see me, wait in the waiting room, make an appointment, and then, we have an interaction in the office. We really need to have lots of interactions. They could be text-based, they could be, message-based, they could be phone-based. I mean, any number of the ways that all of us communicate without necessarily being in a face-to-face environment where we can provide advice, provide guidance, maybe change medications, all those kind of things. So that's the platform that we've developed. We've developed exactly a platform that does those things. And then the third aspect is basically another sort of sad recognition, and that is medication management. So it turns out that we have what are called guidelines that basically are updated, close to annually, if not every two to 3 years at the very least, where new medications are, introduced. We find out maybe good or bad things about old medications that are out there. And so a hierarchy takes place that's saying, if an individual walks in this age group or this gender or this race or whatever it might be, or this comorbidity, this ought to be the first medicine you use because that'll give that person the best opportunity to avoid a problem or to live or to avoid a hospitalization or what have you. Well, what are the odds then across the United States that you'll be on this what's called guideline-based therapy? And it turns out that the odds are about 50-50. If you go to just about any physician in any city, the opportunity to be on the best medicines for your disease process is about a coin flip. So we've dealt with that as well, where we have actually trained pharmacists that are doctorate levels of pharmacy that are working off the guidelines that are saying, listen, anybody that's going to come into this program, we're going to make sure that 100% of them are on the current best guideline-based therapy so that that individual could have the best opportunity from just even a medicine standpoint of achieving the best possible outcome. So you take that, you combine it with the other sort of lever that we have, which is the behavioral aspect, and we take coaches that are trained in behavior science and behavior change theory, and they're armed with the tools necessary to help people achieve lifestyle change. And now you have sort of a virtual program that can take people with various chronic diseases and give them the best opportunity to achieve the best health outcomes.
So I think great sort of elements to that. The appliance of guidelines just reminds me of the recurring theme that I recall from going back years of just applying knowledge that we have in medicine. When you look at the application of aspirin and beta blockers for somebody that's under suspicion of a myocardial infarction, it was 20 years from the point that we understood that. We have a real challenge in terms of applying it, and that's a whole separate show. But I want to go back to another one, and this came up in the presentation, and I heard it, and I'll just declare I completely agree with you, but I've heard lots of pushback, and I'd love to hear your thoughts around this, around the patient-generated information. Take blood pressure as an example. I think if I recall accurately, you said something along the lines, I'd take multiple patient-generated blood pressure readings over a single reading in the physician office. And I can feel some of my colleagues' hair standing up on the back of their neck with, that's not accurate, it's not clinically validated. Talk a little bit about that, if you would.
Yeah, so let's talk about blood pressure. So interestingly enough, there was actually a call to action. That's how it was actually labeled, a call to action that came out from the American Heart Association and the American Society of Hypertension. That was to physicians saying, wake up. The more valuable of the two blood pressures, if you were to put it the way you said it, one is a home blood pressure, one is an office, is actually the home pressure. It's actually better correlated with disease outcomes. It's better correlated with target organ damage. It's the more valuable of the two readings. Not that you should throw away the readings in the office, but the point is if you were given a test and you had to only pick one, that would be the more, assuming that, again, you're getting, appropriately trained in how to take a blood pressure, which we have to do on both sides, by the way. It's not just that we can assume that the medical assistant is always doing it right either. But so when we look at our program, in a 6-month period, actually a 3-month period of time, I think we have about an average of one blood pressure. In the United States today, I'll give you the statistics. In the United States today, half the people with high blood pressure are out of control. These are national statistics, and it's the leading risk factor leading to death across the globe, more so than war or suicide or just about anything else. So hypertension is a big, big problem for us, and it's over 40% of the entire adult population with it, and half are out of control, number one. Number two is those that are out of control, which means it's too high. And again, what's the consequences of that? Heart attacks, strokes. It's the second leading cause of kidney failure in the United States. So again, I mean, it's other organs as well. Those people, on average, with the out of control values, are getting about 4 readings in a year that are recorded. So that's about one every 90 days. In that same 90-day period, we average about 51. So 51 readings that we're getting in over 90 days versus one reading in the sort of the analog model, if you will. Now, think what you could do with 51 readings. You know, I can adjust, I can make changes, I can make recommendations, I can course correct. You know, we can do a lot of things over that 90-day period that you can't really do much with a single reading. And so we're able to double or even triple, in many cases, our control rates compared to the standard of care. So we've actually measured our outcomes. So we said, okay, you know, this sounds all great in theory. You know, show me the results. And what we found is that we've measured patient satisfaction. It's much higher. We've measured blood pressure outcomes or diabetes outcomes in our diabetes program. We're getting better control rates. We have improvements in a whole variety of other factors like patient activation measures and, as I mentioned, satisfaction measures, how people view their health, their overall health and mental health, et cetera. And we've actually got now adherence data so that patients are more likely to take their medication in our program than those that are, you know, in the standard model. And then we even have cost data that as a result of that being under better control, as you'd suspect, there's less heart attacks and strokes and those kind of things, which means obviously there's less utilization of hospitalizations, which is a good thing. I mean, who wants to be in a hospital? So by all measures thus far, we've been able to outperform the analog model, but we still have a lot to do. We still have a lot of learnings in behavior change. I mean, I think we're doing a better job than the standard model, but that's a low bar at this point. And we really want to do an exceptional job in terms of improving behavior.
So for those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Dr. Richard Milani, the Chief Clinical Transformation Officer at the Ochsner Health System. And we were just talking about blood pressure. Unfortunately, I can't pause this show, but for those of you that are listening, maybe you want to pause this and go take your blood pressure right now. That's certainly how I'm feeling as I listen to that. And think about essentially a silent disease. I mean, there are no symptoms. I could have raging high blood pressure at this point and not know it. And it's one of these things that we really have to invest in that, measurement and frequency or sampling frequency. And I think importantly, one of the points that you make is, you know, in terms of that source of data and so forth, your data and outcomes and all of the results based on, I don't want to say limited in a negative way, but, you know, not a huge amount of data is showing enormous benefits from doing that, right?
Yes. I mean, we've got about 5,000 people, so it's a reasonable size. It's not 5 million people, but it's big enough to be able to say that, you know, this is either not working or working. And by every measure we just described, it's clearly working, you know, better than sort of the old model. And it's a way that we can scale this so that, you know, we can do a better job of making sure that diabetics get their A1C controlled and they get their eyes examined and they can follow up with all the appropriate measures at the right time.
So linked to this in my mind was something else that you talked about, which I thought was, you know, sorry for the pun, but genius. And you have your own medical genius bar. I believe it's called the O bar for Ochsner, I assume. Tell us a little bit about that.
Well, we you know, individuals are looking for help, and there's a lot of great apps out there. You know, there's a lot of lousy apps out there, so let's not make them all great, but there's actually estimated between about 180,000 and 200,000 health and wellness apps that's available, which is an awful lot. And of course, there's no regulation on who needs to make an app and what it has to prove. But among those thousands and thousands of apps, there are some real nuggets. I mean, there's some really good ones that could help people and guide people towards whether it might be healthy eating or anything else that we want to be able to do. So how is a person supposed to find it a good one? I mean, I guess you can go online and look at various ratings. And moreover, if you were sort of not so techie, how would you be able to incorporate that in your life? And we felt it was important that we provide almost a library, a curated set of these apps for people to find and to have some help with in terms of if they wanted to accommodate those into their life. So we created this concept called the O bar. To your point, it's much like the Apple Genius bar. We have a genius or two behind the bar, and we have these curated apps on iPads that are at the bar, and they're in our primary care areas. And if patients are walking past or they're directed to it, we can help them find an app that might be something they're interested in, that they might be help with. And we also sell digitally connected devices. And what are those? And those are things that, let's say, back to the blood pressure. It could be a blood pressure cuff that will even show you how to use, and will connect it to your smartphone Bluetooth, and so that the information can go directly in your medical record. So the days where we would tell you to track your weight or track your blood pressure or track your blood sugar, write it on a piece of paper, and the next time you come in, show us the diary, it could already be in your medical record for us to be able to pull up and evaluate. So those are digitally connected devices that we also provide at the O bar as well.
So making the right choice, the easy choice, and doing it in a way that's supportive for individuals that, have a struggle teasing out what's an appropriate, good choice through all of that. Just, I think very, very clever, very exciting. I'd love to see that rolled out in a broader sort of environment. We've got a couple of minutes left. I just wanted to talk a little bit about something else you mentioned, which was social contagion. As an influencer of positive. I've seen this. I think you can see it both on negative and positive, but I think you're looking at this from a positive standpoint and how we can positively impact. How are you dealing with that?
Well, I think I don't think we're doing enough. We want to do more, but it is exactly as you said. We know that both negative and positive behaviors are spread much like a virus through your social contacts. And I say a virus meaning that they're contagious. And we know that stopping smoking, as an example, has been tracked to be able to spread through society, through friends and contacts with different levels of strength. And so the concept that we have is to be able to try, if given an individual's permission, to be able to contact key members of their social network that could help us in terms of, enabling positive behaviors. And there's been lots of studies on this that have shown that it really does augment good behavior change by actually stimulating the behaviors of those around you.
So from my perspective, absolutely fantastic. I think, hang around happy people, you tend to be happier. I mean, it's a sort of old adage. And, I think what you're doing is reaffirming that. Unfortunately, we're reaching the end of time. I just wanted to give you a minute or so just to sort of close out with any thoughts about where things are going for you and the program.
Well, we're adding more disease states, and that would include COPD, which we just launched, and then we have a whole bunch more on the table that we'll be launching over the next year, and we're adding people to the programs, and then we're also spreading our programs beyond our geographic region. Because we are virtual, we have the capability of being able to provide this care just about anywhere. So I think there's a lot of opportunity on the docket going forward.
Fantastic. Well, it just remains for me to thank you for taking the time. I love the presentation, love the discussion, learning a little bit more and digging into it. Thanks for joining me, Richard. It's been a real pleasure.
Thanks, Nick. My pleasure. Great to be with you.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at Dr. Nick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com, and tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.